COVID-19 is making a significant impact in Volusia County. We're here to talk to our local medical doctors about what they're witnessing in our community. And we also want to talk about the facts surrounding the COVID-19 vaccine. I'm Kevin Captain, Volusia County's Community Information Director. Now, we're not here to force anyone into vaccination. But if you're not vaccinated and you're on the fence and you want a little bit more information, then this program is for you.
I'd say get the vaccine. It can't hurt, even if it doesn't keep you from getting it. It'll at least help you get through it.
For yourself, for your family, for your loved ones, get the vaccine.
We're at the Volusia County Emergency Operations and Sheriff's Communications Center in Daytona Beach. We're in the operations room, and this is a big physical room, and we're physically distanced apart from each other more than 6 feet. So we can safely have this interview and conversation without the use of our masks. We are also all fully vaccinated. With us today is Dr. Joe Smith. He is the Chief Medical Officer for Advent Health, Daytona Beach. Also with us is Dr. Margaret Crossman. She's the Chief Medical Officer for Halifax Health. And also with us is Dr. James Fulcher. He's the Chief Medical Examiner for District 7 Medical Examiner's Office for the state of Florida. Thank you all, doctors, for being with us. Your schedules are very, very busy. This is an important message. This is a plea to our community. So first off, if we could just discuss what's it like right now in the hospitals. Dr. Smith.
So, Kevin, right now, I would say we are coming off of a surge or an influx of patients that none of us ever anticipated we would face in our careers. Right now, I am at approximately double the highest surge that we had in 2020, and that represents about a 30% reduction in the number of COVID cases I've been treating over the last month. So, as busy as we are starting to actually feel a little bit of breathing room right now.
What's it like at Halifax, Dr. Crossman?
Yeah, so we all know and have felt firsthand this Delta variant has a shorter incubation. It's producing higher viral loads. It's more easily transmitted than former strains. Cases have doubled every 8 to 9 days leading up to this surge. And the original strain, I think that doubling happened about every 21 days. So it's a very different strain. In general, those counties with higher vaccination rates tended to fare better during this surge. There were some exceptions, including the density of the population and certain activities that happened in a community, tourism, things like that certainly impacted what happened at Halifax. At Halifax Health in August, we certainly set a new pandemic record. In the month of August alone, we've had around 450 COVID admissions with 180 COVID patients in our hospital beds on August 19th. That was our highest number in-house patients, and that was our peak. This is 3 times our former peak in January 2021. And on average, 85% of our hospitalized patients for COVID are unvaccinated. That's what we've been seeing.
So it tells us a lot about the efficacy of vaccination.
Yes.
It does. You know, Kevin, you hear a lot of people talk about how, you know, now, particularly with the Delta variant, you're seeing people that can become ill or even hospitalized, sick enough to be in the hospital after the vaccine. While that remains true, what we're seeing is that less than 5% of our patients in the ICU, so the sickest patients, are fully vaccinated. So while it's true that as this virus mutates, you can still get sick, and that's why we're still wearing masks, we're still asking folks to stay home when they're sick, it does seem to protect you from the most severe manifestations of this disease, which is respiratory collapse and having to go on either heart-lung bypass or a ventilator or breathing machine. So the sickest patients are those, unfortunately, that have foregone vaccination.
You know, and Joe, I appreciate you bringing that up, the outcomes, the difference for vaccinated versus unvaccinated. I know the ages of those that are hospitalized for the vaccinated versus unvaccinated is a difference. For instance, for all of our COVID admissions currently over these last, say, 3 months since we've had vaccinations available and more people vaccinated, the average age of our admitted COVID patient is around 60. But if you look at specifically the vaccinated group, that average age is around 70. And if you look specifically at the unvaccinated group, that average age of hospitalization is around 55.
So going back to last year in March when we first entered this pandemic, and all last year, even through today, both you, Dr. Smith, and Dr. Crossman have been very influential in educating our community here in Volusia County with what's been happening at the hospitals, more that we're learning about the pandemic. But with us today, what's so unique is to have you, Dr. Fulcher, because we know that with what we're hearing, your operations have been affected greatly, especially by this second surge. Tell us about it.
So our operations have been significantly increased. All-cause mortality is up. People are dying younger with this variant. We're seeing people die in their 30s and 40s. Most of them have some comorbidities at that age, but our younger populations don't necessarily have those comorbidities, and we're still seeing them die. For my office, the problem is we're taking jurisdiction over these cases because some of these cases meet our jurisdictional criteria in that they may have a substance abuse disorder or require an autopsy or further investigation because of some other factor in their life, be it violence and or substance abuse. So our load is significantly up during this most recent surge because of the younger population and the lifestyle choices some of them may or may not have.
Well, one thing that we've discussed through the pandemic is the effect that it's had on one's mental health.
Sure.
And when you talk about substance abuse and some of the other environmental factors that come into play with someone's lifestyle,
right?
That's obviously something that's changing. Does that change the criteria by which you decide if something merits an autopsy?
Absolutely. We're having to do antigen testing or PCR testing on most of our decedents to make sure they don't have COVID. I will say that, and this is something we did not predict, our overdose numbers nearly doubled during the pandemic. And we believe it's because people with substance abuse problems, disorder, did not do well during the pandemic. The isolation, all the various shutdowns of things that the community was doing for them dramatically increased the number of overdoses. It was, I believe, almost a 70% increase. And in our county, unfortunately, with our fentanyl problem, which is a totally different problem, it didn't go away. In fact, I would say the amount of drugs on the street seemed to go up. It was a vast amount of fentanyl in the area.
So what you're seeing more, would you conclude it's more intentional?
No.
Non-intentional?
It's accidental. It's seemingly all accidental. And I guess at the end of the day, the illicit drug trade did not take a break during the pandemic. They probably ramped up. And there were people that wanted drugs, and unfortunately they got them. So that was probably the most dramatic increase for my office, was just those people having such a high incident of overdose in this pandemic.
So Dr. Fulcher, when a patient dies and they go to the medical examiner's office, does everybody undergo an autopsy, or what merits the requirements of an autopsy in this jurisdiction?
Sure. So in Florida, the offices of the medical examiner, their jurisdiction is very clearly delineated. We take jurisdiction over deaths that involve foul play, unnatural processes such as an accident, a homicide, poisonings, intentional overdoses, anything like that. If it's strictly a natural disease process with no suspicion of foul play or abuse or neglect, we don't take the case.
Okay.
It's not our jurisdiction. So the vast majority of cases of COVID fatalities do not fall under my jurisdiction. I will only get involved if there's a confounding factor, such as a substance abuse disorder or some activity of violence or foul play. With that said, even the bodies we take don't all get a full autopsy. With these COVID cases, we've had only a few. We've done testing, and if it comes back positive, we've done a limited as an examination as possible, fearing, of course, contamination of my space with the virus. So very clearly defined jurisdiction.
That clears things up. I've probably been asked this before. In your field, with coroners, medical examiners, have there been any identified cases where practitioners in your field have acquired COVID as a result of doing an autopsy on someone who was positive COVID?
No, actually, to the best of my knowledge, no one has been able to verify that type of transmission. And I think, to our credit, we have a very limited interaction with the decedents, like time-wise, and we completely control the environment. First off, our risk is vastly reduced because they're not actually breathing, obviously. The biggest issues with us are suction, and then autopsy saws, bone saws, create an immense amount of aerosolization.
What is herd immunity anyway?
Herd immunity, Kevin, is the reason why I have never seen a case of measles as a physician, and I'm in my 40s.
That's great.
Herd immunity is when you are surrounded by people who are protected. And so let's say I have COVID, okay? I have COVID-19, and maybe I'm very sick. Maybe I don't even know that I'm spreading this. And let's say that you and Dr. Crossman have been vaccinated, but he has not been, right? And we come into contact, just like we're sitting here at the table. Well, if Dr. Crossman's vaccinated and we talk, I'm probably not going to transmit this to her. You and I talk, and I'm probably not going to transmit that to you. And then when you talk to Dr. Felcher, he is going to be protected because you were protected, right? Even though he himself wasn't vaccinated in that scenario. That's an example of how herd immunity works.
So it provides that nearby immunity, that passive immunity, so to speak.
It's almost like a forest fire, Kevin. If you look at a forest fire, you can only burn trees that haven't been burned before. When we reach herd immunity, enough of us are vaccinated that the fire, or the virus in this case, doesn't have anywhere to spread because it's only encountering burned wood or vaccinated people. Unfortunately, we still have about half of the population out there that hasn't gotten vaccinated. And so there's still plenty of wood to burn in this forest fire.
So that's a great metaphor, and I think it's one that we all can really very easily understand. And when you say that half of our community is vaccinated, how much do we really need to reach herd immunity? Some sources say 70%. I've heard some say 80, 90. Where is that magic number?
Yeah, so the herd immunity is certainly a certain percentage of the population is immune, whether through vaccination or natural infection. And that's going to provide protection because the epidemic will burn out. And you're going to protect those that aren't protected. The herd immunity threshold is what you have to talk about when you're talking about how much do we need out there. And that's tied to the basic reproduction number. The basic reproduction number is exactly what Dr. Smith was saying, which is, if I'm infected in a totally susceptible population with that original strain that we had of this virus, I'll probably infect 2.5 people. Its reproduction number was 2.5, roughly. When we had the alpha strain come along, it went up to, say, around 4. And then here comes the Delta strain, and it's approaching 6. In other words, if I'm infected, everyone's susceptible, then I'm going to infect roughly 6 people. And every time that basic reproduction number goes up, as it did from strain to strain, that means that threshold, what percentage we need to reach of immunity, goes up as well. So we started the original strain around a 60% threshold is what we were looking for. The alpha went up to 70, and now the Delta has brought it all up to maybe 80% is what we need to reach.
But in the case of like natural evolution, that's what you expect to see with viruses, right? Where they mutate, because you mentioned some of the different mutations that have occurred with COVID-19. And those mutations they're natural to expect. But at the same time, with each mutation, is it normal that we see that, would you call it an R naught before the contagion part of it gets more virulent?
It depends on the mutation that happens. It can get less virulent or more virulent. And in this case, this particular strain, those strains that got less effective and efficient at transmitting, they're not contenders. Delta came through, it was a contender, and it had all the right mutations to make you create a higher viral load, and it enters cells more easily. It just did all the right things to become a more contagious, more infectious virus strain.
So successful in that mutation, Kevin, that Delta is now 95 or more % of what we see in terms of circulating COVID infection in the community, which is really incredible when you consider how short of a period of time this thing had from really kind of being first recognized in mainland China in late 2019. Here we are in mid to late 2021, and that original strain is almost gone. We just don't even really see that. So it's really incredible that something has fine-tuned its game to bring us to this point that it's now 95% of what we see circulating.
So do we expect that to continue? So as long as there's the opportunity for the virus to mutate amongst people that don't have antibodies to fight it down?
That's right. So we have provided this virus with a fertile field of unvaccinated people out there that have, not deliberately, but have afforded this virus the opportunity to continue to change itself up. So I am of the belief that had we had wider vaccine adoption, we may not have seen the emergence of a Delta variant.
You know, the CDC has estimated that just prior to the vaccine rollout, roughly 30% of Americans, maybe 1 in 3, I think is the number that I saw, had been exposed or infected. So that was based on the fact that they had maybe 26 million reported cases, and they estimated there's a certain percentage or a certain number for every reported case that was probably asymptomatic or with minimal symptoms. So let's say we started with, say, a third of the country exposed. Enter the vaccine rollout. 50 to 60% of eligible individuals now are vaccinated across our country. Some spots better than others. But we can't add those two numbers together, unfortunately, because many people are in both groups. They were infected and or vaccinated. Right. So my guesstimate is if truly by the vaccination numbers were close to 60% vaccinated across the country, at least for the eligibles, then maybe if you add some of those that have been exposed and infected and therefore immune, hopefully we're around 70%. And maybe with this most recent surge, we're going to have quite a few more exposed, infected, unfortunately. Right. But also the vaccination rollout has taken another step in the right direction because people took note of this and started agreeing to that vaccination. And so those numbers are going up, and I hope within the month we'll see that we truly have hit that 80% threshold we need.
And so we really need a few more people to get the vaccination.
Yes.
And I think that's why we're here. I would say that Dr. Crossman and I are really tired of telling young, healthy people with families that their loved one, is doing so poorly. I think Dr. Fulcher is at a point now where he's saying, "Hey, I'm the busiest I've ever been," which is an ominous realization to come to. And if I didn't think it was possible to get us from where we are now to where we need to be to tamp this thing down, I wouldn't be here, Kevin. I'd be back at the hospital doing my best to take care of folks. So it is possible. We're closer than we've ever been, I think, to getting over that threshold.
Great points. You know, we've been saying for how long about masks. You know, they're there to protect mostly others, but it's also there to protect yourself. And if you get vaccinated, then you are not going to be the vector that helps transmit or allow, like you say, the opportunity for further mutation of this virus.
The life you save may not be your own with either the vaccine or with the mask. And it's quite possible that you would have been one of the silent infections Dr. Crossman was talking about. Some folks just don't get very sick with this. But it's also just as likely, if not more likely, that you would expose someone who's going to have a poor outcome or a severe course of illness if you don't do those things.
There are some people that feel like they don't want to get vaccinated or they're learning more about it. But then there are also some people who would love to get vaccinated but medically are ineligible or can't because of an immunocompromised state. Let's talk about those. Is that true?
Yeah, there are some who, and it's pretty rare to have an allergy to the components of the specific vaccines that are available right now in our country. So pretty unusual, but there are a few people who may. And then there's another group of individuals who, because of treatments they're undergoing, it's not advisable, and some, quite honestly, that just won't mount a good immune response to the vaccine. So we'll always have those that are vulnerable and that need the herd to step up and help with protecting them.
But largely, that immunocompromised population, that's exactly who really is going to benefit from this. And so, we had talked earlier about some of the misinformation. I'm sure, you guys, we all get these questions all day long. One of the questions I get over and over is, hey, I'm at an immunocompromised state. I have an underlying illness that predisposes me to infection. Is it true that I can't get this vaccine? I always stop what I'm doing, put my phone down, look that person in the eye and say, no, you absolutely are the person that needs to go and get this shot.
Good advice, definitely.
And I will share a story. A 79-year-old individual who I happen to know, who unfortunately was a smoker, smoked 40 years of her life, and had in her home someone who brought COVID into her home, but she had been vaccinated. She ended up with a mild illness, lost smell, lost her taste for a few weeks, and pulled right on through. And to me, that was an amazing save, that individual was vaccinated at the age of 79 with her smoking history. That should have and would have gone another direction, I'm confident, had she not been vaccinated. So even those with a lot of complex illnesses or medical histories, and certainly those that are immunocompromised, all of them should be vaccinated if they are able. There are cases where they, because of treatments they're undergoing, should not, but their physicians will give them guidance on that. Otherwise, everyone should.
Kevin, while we're shooting down myths, another one I get all the time, and probably you too, Dr. Crossman, is women of childbearing age. There are a lot of women of childbearing age who are very concerned because this is a relatively new modality. Sure. Again, I couldn't be more clear. The American College of Obstetrics and Gynecology, ACOG, the Society of Maternal Fetal Medicine, which is, if you've ever been referred to a high-risk OB, that's the governing body of scientists for that. They are monolithic that absolutely this is safe in pregnancy, safe if you are lactating, safe if you are thinking about becoming pregnant. There is absolutely nothing out there in terms of credible research or even an inference from data that's out there that says that this does anything to impact your fertility or is in any way unsafe if you are pregnant. If anything, we have a mountain of evidence on the other side that says that women who contract this while they are pregnant have an increased risk of bad outcomes. And so it's even more important, again, in that population for those patients or those women to consider vaccination.
And I've heard of cases like that too, and when it first started, we saw a lot of death that was occurring in our senior population. But now, as you said too, Dr. Fulcher, you're seeing a much younger population of people that are succumbing to this devastating illness.
Yes, absolutely. And I believe a lot of it's not being vaccinated, not wearing masks. And, this is Florida. People are outside. There's a lot of activity outside, a lot of crowds, and people are taking risks. And in the populations I see, they're taking a lot of risks, and a lot of them are getting really sick. And while we're shooting down myths, I'd like to bring up a point that there was some effort in the beginning of this pandemic to say that these people really weren't dying from COVID. I'm here to tell you, dying is multifactorial. Just because someone has comorbidities doesn't mean they didn't die of COVID. You don't get to say, oh, they had heart disease, therefore it couldn't have been COVID. And there was a lot of effort put into downplaying these deaths. If you're in your normal state of health, whether it be good or bad, in some of these cases particularly bad, and something acutely happens to you, that by all definitions, legally the CDC is a COVID death because something acutely happened to you. You were fine 2 weeks before you got COVID, and now you're dead. So none of the other comorbidities negate that.
And that's an important message for someone who might be young and healthy and not have comorbidities, but they could still succumb to
Absolutely, yeah. Like we said, probably in the 40 and 50 age range, we're seeing people die without significant comorbidities. And I will tell you, most of them, as far as the most common comorbidity we're seeing is obesity or even being overweight. And unfortunately, our population here in Volusia County, we have a very large number of people that are overweight or obese. And in our experience, they're doing much worse, even at a younger age, than people that are thinner.
Good point. Speaking of, lifestyle changes and things, there's a lot of talk about supplements and things like that. What kind of cases are you seeing relative to that?
I think because this population of patients that I'm seeing might have even more mistrust of the medical establishment, they're actually dying at home. And we're seeing them die at home surrounded by zinc supplements, probiotics, and any number of things that absolutely don't work. And they're getting, like they said, a lot of misinformation. And, you know, it's a virus. Maybe it waxes and wanes. They convince themselves they're feeling a little bit better, and they don't get medical treatment. And then they end up dead at home, unfortunately, surrounded by things that have been, for lack of a better term, peddled by misinformation peddlers, I guess you'd say. People that have, and I don't know why they have this incentive to say that these things work, because the medical establishment certainly says they don't. And it's kind of surreal. In fact, we have seen very, very, very few people vaccinated die with COVID. Most of them had significant comorbidities, immunosuppression. Mm-hmm. I will tell you, my office has done 0 fatalities related to vaccination. In my office.
Zero.
None. And we've done hundreds of cases that have died from COVID. And I'll tell you, just speaking to the lethality, from autopsy studies that we've seen, this is a very dangerous virus, and it will kill you in ways beyond your lungs. So you're not going to get a pass on it because of your own, your feeling of health or how healthy you are. It can easily kill healthy people.
Because it causes coagulopathies and blood clots and things like that.
Yes,
too, right?
Absolutely. Yeah, the Florida Association of Medical Examiners had some studies presented where there were very significant coagulopathies presented at autopsy, places you would not expect. And we were talking earlier that we expect that these long COVID people are probably going to have additional sequelae and disease states occur months, years down the road because of microvascular damage that occurred to their organs. And they may not manifest immediately, but it'll catch up to them. We're talking about the brain. We're talking about the kidneys. We're talking about small infarctions or heart attacks in the heart, precipitated by the virus potentially. Any number of possibilities. So very dangerous.
So that could certainly be added to the list of long-term effects.
Oh, absolutely. I mean, I know people, an ER doctor where I came from that has a pretty significant heart condition now due to COVID. She actually got COVID from a colleague, regrettably. But very sad, and no comorbidities. Just sometimes it affects people differently.
Well, you mentioned measles, and I'm actually glad that you mentioned that, because when we're talking about vaccine misinformation, and you look at where we're at today and what diseases we've been able to eradicate throughout the world, I mean, it's amazing. And there's still some ambivalence people have because they hear the word RNA or DNA and they think it's going to get into the nucleus of our cells and alter the way our cells reproduce. But they're proven to be safe.
Absolutely.
And effective.
Absolutely proven to be safe and effective. In fact, what I like to say back to that is if you don't like the idea of a little bit of the mRNA, so essentially a fragment of this virus being injected, you're really not going to like the idea of this virus hijacking your body's symptoms to produce millions and millions of copies of itself, because that's going to come with all sorts of genetic material.
And the long-term effects like we're just talking about. Smallpox, another great example. It's been eradicated from the world, right?
Smallpox, we really, I'd said I've never seen a case of measles. Chickenpox is really not a major player anymore. Polio. This is what our world looks like without one vaccine for one virus being fully deployed. If we imagine the world without any vaccines, it's a really scary place to think about. And so I say that to say that vaccination is hands down the most effective invention of the medical community, really over the history of time. More effective than surgery, more effective than any medication. Your grandma had it right. An ounce of prevention is worth a pound of cure. Preventative medicine is still where it's at, and mathematically so, demonstrably so. And so if you really want to change the world, vaccines, right? Vaccines have made things so much safer for us. We take it all for granted. I would just hate to see that this continues to play out and we continue to see people die needlessly because they're afraid of something that's so proven.
It's important for everyone to know that the indication for monoclonal antibodies has been expanded. It's not just for those with comorbidities or the older patients or those that are immunocompromised. It's also to prevent you from getting it. So if you're someone who is concerned, 12 and older, and you've been exposed, and certainly if you are concerned that you could be at high risk for progressing, and as we're seeing, younger healthier people are progressing to very severe disease. It's not a bad idea to have a conversation with your physician early in the course of this infection and see if perhaps monoclonal antibodies are something that would benefit you.
Well, I know the governor has been championing sites throughout the state offering the monoclonal antibody. Would that be similar to if you're bit by a dog that potentially has rabies and you get that immune globulin injection? Is that kind of the same idea?
Very similar. In this case, then it would be an antibody that's been synthesized in the lab that knows how to attack this virus and keep it from entering cells and replicating. So you don't mount the viral load. You don't have the destructive things that cascade after the virus gets in and sets up shop.
But the important thing there is you're not providing immunity to the patient like a vaccination would. You're only giving it passively, correct?
Correct.
The body's not going to make it.
Yeah, the body's not going to make it at that point. The body is not going to be working on as much of an immune response as if you had not had the monoclonal antibody. It's going to protect that person for that point in time. But that kind of runs out of the system at about a month or so. And it's recommended that if you've not been vaccinated, that maybe 3 months later, you consider getting that vaccination at that point in time, especially if you had monoclonal antibody. You should wait. Otherwise, it could interfere with your body's ability to mount a response to the actual infection.
Most of us at this point knows somebody who has succumbed to the disease or has been hospitalized on a ventilator. What cases can you talk about, maybe de-identify, to just bring to light the emotional significance that families are going through, and particularly for those people who might be on the fence still with deciding, is vaccination right for me?
You know, I have been given permission by our chief nursing officer to talk about her story. She has a 43-year-old son who has been on ECMO, which is heart-lung bypass, in our ICU now for weeks at Daytona campus. And his name is Josh, and he was the only member of that family that didn't get vaccinated. And I have heard over and over, that, there was this wish, maybe if we had pushed him a little harder, maybe he wouldn't be in that situation. Or, if maybe there hadn't been so much misinformation out there, maybe he would have made the choice to get the vaccine. Some of the most heartbreaking feedback I've gotten from some of our nurses is they tell me over and over, as patients are critically ill, I'm talking, about to be sedated so that we can put a breathing tube in, those patients will say, is it too late to get the vaccine? And it's so hard to say yes.
I bet. Yeah. I bet. Thank you for sharing that.
One of the things that I think is so telling is that we've had, over these past few months where we've been tracking who was vaccinated, who was not, we've had no deaths in the vaccinated group under the age of 60.
Wow.
The age range of our deaths have been 24 to 91.
Yeah. We're seeing them in the 20s too, for sure.
And there was a married couple. They were unvaccinated. They were in their 50s, and they had had COVID symptoms for just over a week, both of them. They came into our facility when one of them became more short of breath, and the other was just feeling like, I'm not getting better. So they both came in. They both qualified for admission at that time. They actually were beyond the 10 days, so they couldn't get monoclonal antibody. And of course, they were given all the treatment that they needed at that point in time. The husband went on to require high flow oxygen, and he stayed there, as most of them do, for a couple of days. But fortunately, he turned a corner and he started improving. His wife, on the other hand, progressed to need mechanical ventilation. By the time he was ready to be discharged from the hospital, our team had to approach him about end-of-life decisions for his wife. And on the day he was discharged, he was rolled to her bedside, and there, when all the artificial support was turned off, to be with her. And he went home a widower. And those stories just, 2 weeks prior, they were a happily married 50-year-old couple.
Wow. I mean, that's a message all its own, just to get vaccinated. And Dr. Fulcher, you're seeing people that don't even make it to the hospital.
Yeah, so we have families affected, obviously. We don't have as much interaction with the families, obviously, as they do clinically. But I do know we've had families, sisters, brothers, end up dead in the same home, both COVID. Neither one of them got medical care. We've had any number of calls from family members wanting us to test people for COVID. They're worried about it. And I think what they're getting, I don't think they use the word, but there's a lot of guilt here, a lot of guilt. And I can't imagine refusing the vaccine and then having to think about that. It seems like a real dangerous game to play. The vaccine has such little risk to know that, in Dr. Smith's example, the trees are going to burn. The tree that may burn might be the one closest to you. Who are you going to give the virus to? It's not going to be someone in California. It's going to be your brother who's immunosuppressed, can't get the vaccine, your elderly mother. And we see a lot of that. Older people die, and then, of course, there was a birthday party or something, or there was an event, and we wanted to blow out the cake, and that was inconvenient to have the mask on. And then everyone was singing, and, I didn't get vaccinated. I'm a healthy 24-year-old man. I do fine. Unfortunately, my 98-year-old grandmother doesn't do well. So an incredible amount of guilt. So please get your vaccine.
It's doing it for them. Definitely.
We had an obstetrician who, up until this most recent surge, she, after losing one of her COVID patients, it was one of her pregnant patients, she actually wrote a heartfelt letter and distributed it to all of her patients. And this happened simultaneous with ACOG reviewing mounting information about how people were doing vaccination versus those that were unvaccinated. And so they came out with statements simultaneous with this happening in her own patient population. And she wrote this compelling letter to the rest of her patients and has just urged them to get vaccinated. What we've seen is a lot of pregnant girls, again, otherwise pretty healthy, who in their late second and early third trimester, it's somewhere around there, that many of them are getting into trouble. And some of these patients then are admitted. Some of they're having to have their babies delivered early in many cases to increase the chance of survival for mom and baby. They're away from their family for extended periods of times. And if they go home, they're going to have all the sequelae of the prolonged hospitalization and what it's done in their system. And quite honestly, just the other day, we were on a state call, and a lot of the medical leadership across the state are making plans for how are we going to address all the pulmonary rehabilitation that's going to be out there. We've got to ramp up because so many individuals are just struggling just to walk without getting short of breath. They're rolling around with oxygen tanks that they never needed before. Yeah. And it's very difficult for many of them to resume life as usual. And that includes these young women who now have hopefully a baby. It might have been a premature baby that needed to stay a little longer in the hospital, but are now at home and trying to get their lives back on track.
For these younger people, the quality of life issues, even, outside of pregnancy, if you're a healthy young man and all of a sudden you can't breathe now, what sports did you like to play? What activities did you like to do? You may survive, but your life may be very significantly limited because of this virus.
Really, I guess at this point, just tell us what you would want the audience to hear as really a plea for vaccination. What are your closing thoughts, Dr. Smith?
My closing thoughts are, if you made the decision in 2020 that you wouldn't take the vaccine, or in early 2021 because there wasn't enough data, or because you were young and healthy, my closing plea is please take a look at what is going on now. The Delta variant, this mutation, has absolutely changed the game in such a way that I believe you will be compelled to get yourself vaccinated if you see what we are talking about. If you look at the data, it couldn't be more clear that this is a safe, effective vaccine. There have been hundreds of millions who have gone before you to prove that. There's really no good reason at this point, in the vast majority of cases, that you would say, no, thank you. Again, the life you save may not be your own. It might be the person, like you said, right next to you. And so please, take a look at what's going on today. Freshen up that inventory of your own research And I think you'll come to the same conclusion we have, which is that vaccination is the best tool we have.
I think until we reach that herd immunity threshold, we're going to continue to have outbreaks. Outbreaks are how this virus is supercharged into mutating. And so to finally move past this, we're going to have to find a way to hit that threshold. And that means behavioral change, so using focus, mitigation strategies, and then vaccination, timely vaccination. You know, if it's spread out over the course of many, many years, it's not going to happen. The virus will continue to mutate. But if we have more step up and help us get to that threshold that we need between that and the natural infections that have occurred, I think we'll be able to move past this. That's my hope. That's my prayer.
The vaccine's safe. The vaccine's effective. The vaccine's been shown through countless uses that its risks are vastly less than the virus. I'll tell you from our experience, the virus is deadly. We know it's deadly. Anyone that tells you it's not deadly is wrong. And briefly, I wasn't going to bring it up, but there's such a thing as confirmation bias. And the misinformation thrives on this, that and social media. Everything we're telling you is from a peer-reviewed journal. It's from our own clinical experience. It's from a good medical resource. The other side doesn't have that. They have a lot of smoke and mirrors is basically all it is. It's anecdotal speeches from people that, if you're looking at them on your social media account, you may not even know that you don't know their credentials. Let's be blunt. You don't know who they are. They're in another state. You have no idea who they are. So the information they give you is it's not as good as the information we're giving you. It's really not. It can't be. It wasn't validated clinically. It's just an attempt to make you make a decision, and I don't know why they do it. I really don't. But confirmation bias.
So a common question that comes up is, let's say I got COVID and I built natural active immunity against the virus. And a month later, I'm fine and dandy. Do I need the vaccine, or should I get it?
You should. In fact, I'm in that group. I had COVID. I had it in the first wave. Fortunately, I didn't get terribly sick. And then several months later, I went and took the vaccine. So I did my research, and I came to the conclusion that was going to help me stay safer longer.
Excellent.
I know that is a difficult decision for many people, and I do know individuals who are following their antibody levels, and right now we don't have data that tells us, you're definitely protected or not, or for how long. However, that said, I would also say that I've observed people 6 and 8 and longer months out from their infections who had pretty good infections, and they appear to still be very, very protected. So I don't want to discount herd immunity contribution from those who were infected. That said, you may be among those who didn't mount as much of an immune reaction for a variety of reasons. So that vaccine would be like a life preserver, just
Right.
an extra little measure of protection to polish off your protection from this virus.
An extra boost.
Yeah, the cost of the vaccine is negligible compared to the benefit it could add. It really is.
In your operations, are you having to do more personal protective equipment or things differently in that
Yes.
nature during the pandemic?
Definitely, Kevin. Before COVID, we were using surgical masks. Basically, that's what most medical examiners in the country. We've now switched to either N95s or PAPRs, powered air respirators. It really provides a level of protection. There are procedures at autopsy that produce aerosolization. And while it hasn't been shown to have been spread during autopsy, I think it hasn't been shown because medical examiners have been so proactive with their respiratory protection. Our protocols are vastly different than they used to be. We're screening more effectively with antibody and PCR screening, and we have an ancillary trailer we're using to store bodies in isolation. In my new facility, we'll have actually a built-in isolation cooler as well. So many things are changing in our practice.
So, Dr. Fulcher, you have a customary amount of autopsies that you do. now you're seeing more younger patients come to your operations?
We are, yes, sir. With COVID, during the first wave, the patients were older. They had lots of comorbidities. Now, with the Delta variant, we are seeing younger patients with fewer comorbidities become sick and unfortunately die. The reason is largely the Delta variant, its increased activity, and then the fact that people aren't as interested in wearing masks and social distancing as they were in the beginning of the pandemic. I think our attitude about the virus has changed. I think younger people, unfortunately, have a sense of immortality. This can't affect them, and it's not true. And they're taking more risks. We're seeing most of our infections, that we take jurisdiction over come out of people in kind of a 50 to 60-year-old age bracket that do illicit substances and may, in fact, be amongst lots of other people not social distancing at nightclubs, bars, restaurants, and they're exposing each other. The long-term effects will be borne out, I think, as time goes on. But certainly from what we've observed so far, people that are middle-aged or so certainly can have long-term effects from COVID. Respiratory compromise, cardiac issues, with the increased thrombosis, small clots in the blood vessels that we see with the virus. I would expect that long-term we will see multiple different organ systems in the people that have had COVID affected negatively. That could be anything from renal compromise to some sort of stroke or even a predisposition to a stroke. Let's say that COVID doesn't cause the stroke immediately, but it damages a vessel in a way that 10 years down the line, during a hypertensive crisis, there's damage there and it ruptures and all of a sudden you have a hemorrhagic stroke. So there's any number of possibilities that can occur, and I don't think we'll really know the full effects of COVID until decades from now.
So back to the immunity that one gets either from having infection or the vaccination. Because the vaccine is a systemic vaccine right now, we're getting our systemic protection. Whereas if someone is infected, they're not only going to have some systemic, but certainly some respiratory tract protection that we may not be getting from the vaccine the way that it currently is. If I had my pie in the sky wish, I would say, let's all get our systemic vaccine first, and then those intranasal vaccines that are in the pike, that's what we need next. After we have our systemic protection, then our next booster would be something intranasal so that we build up our respiratory protection. So that's something that those who've been infected have probably in a little better amount than those of us who simply were vaccinated and never exposed.
I mean, we're starting to joke that COVID-19 is the 19 pounds we've all gained from the sandwiches and the cupcakes and all of the pizzas that have been sent to the hospitals. But hands down, the best way to thank healthcare workers right now, frontline, first responders, get your vaccine.
Wonderful.
Agreed. I would add not staying out long and trying to do a lot of things on your own, or using potentially some unproven treatments on the outside if you are getting ill. Remember that the monoclonal antibody is available and it can avert some hospitalizations and some severe disease. So even if you're not vaccinated, and even if you are vaccinated, if you're getting more ill on the outside with COVID, please come in, get those monoclonal antibodies and do it as early as possible, because that's when they're most effective at preventing serious disease and hospitalization.
Thank you very much.